Welcome to the weekly series of cerebrovascular and skull-based surgery symposiums from University of Miami. On Thursdays, this is our 11th session today. I'm Schwartz-Morcos, professor and co-chair of the department, director of cerebrovascular and skull-based surgery at the University of Miami. The co-directors of this course are my partners, Carolina Benjamin, assistant professor, director of our Keynes cadaveric lab. She specializes in brain tumor and skull-based surgery. And Michael Ivan, assistant professor, director of research of the Brain Tumor Initiative, specializing in brain tumor, skull-based, and epilepsy surgery at the University of Miami, as well as my two endovascular, open vascular partners, Bobby Stark and Eric Peterson, Bobby being the director of endovascular research. You know where we are in beautiful Miami, even though we are COVID challenged these days, but still a beautiful city. These are our two main hospitals, University of Miami Hospital and Jackson Memorial Hospital. We started this series on May 21. You can see the series of lectures we've had. This is the link to access all of this information. As you can see, this is where we are today. This is what is still in store coming well into September, and all of this information is available on our website. Please, for audience members, use the Q&A box to send your questions throughout the evening. My co-directors and the panelists, myself, will help in selecting the questions to pose to our panel. We do not offer CMEs. Please share this information on your own social media if you think these sessions are worthwhile. Our two main speakers today will each speak for about 25 minutes. I might interrupt them 2 minutes before the end just to remind them of the time. Now, this is new this week, so all of you in the audience, as I am planning the remaining sessions in September, October, and probably into the rest of 2020, we are very open to suggestions. So please, if you have specific topics in vascular or skull base you would like to see covered, just email me. You can see my email there, or even put them in the QA box here tonight. Or you can, if you follow me on Twitter, you can send me a message on Twitter, whether it is topics you'd like to see or specific speakers you want to hear. We've, of course, we'll look at everything. A teaser for next week. Next Thursday, we have my colleague, neurootologist Simon Angeli, who's going to talk about the temporal bone and what a neurootologist can teach the neurosurgeon regarding the temporal bone and the tailored approaches. And my very good friend, Miguel Arayez from Malaga, Spain, to discuss surgery of petrous apex pathologies, philosophies, strategies, and techniques. And for panelists, we will have all-star lineup: Fred Gentili, Anil Nanda, Jamie Van Gompel, and my very partner here, Mike Ivan. Now, Mike Ivan has also been running a very successful Wednesday symposium called the Miami Global Brain Tumor Symposium that mixes in skull base as well as intraaxial pathologies. And we're very happy to see Aaron Cohen-Gadol be the next Wednesday speaker. Is going to talk about pineal region tumors. Many thanks to the team that makes it happen. I thank them every week, and I'm sure many of you have been to many of the sessions, but we'll never stop thanking them. Ingrid, Roberto, Christina, and Ignacio, who's running this webinar. This is the link again. You can find everything you want, including recorded sessions from the previous ones if you missed them. You can email us, you can email me, as I said, Twitter, you can do Instagram or departmental Twitter as well. The topic today is this: anterior skull-based meningioma. Should we do it this way, transcranial at the top, or should we do it expanded endonasal at the bottom? So first, let me introduce the panelists. Great pleasure to introduce Ian Dunn, who's professor and chair of neurosurgery at the University of Oklahoma. he moved within the last year and a half, is already transforming that program. Prior to that, he was at the Brigham. Thank you, Ian, for being here. My very good friend from Mexico, Gerardo Guinto, a leader and a phenomenal surgeon at the Universidad Nacional Autónoma de Mexico, UNAM, in Mexico City, a fantastic skull-based surgeon who will participate in the debate tonight. He's professor and chair. Madison Michael, very involved in the North American Skull-Based Society as a secretary and a friend for many years, professor of neurosurgery at the University of Tennessee, Memphis. And I have to thank him publicly today because he sent me, among his colleagues, his fantastic resident who is currently my fellow. So thank you, Madison. He is a spectacular individual, Nick Kahn. And Ted Schwartz, who may be joining us a little late. I haven't seen him as of 5 o'clock, but it's a fantastic pleasure to have Ted as well. He was actually our speaker a few Wednesdays. And of course, Ted needs no introduction. He's at Weill Cornell and one of the pioneers particularly in endonasal transsphenoidal surgery in New York. On to our two main speakers for the evening. Daniel or Danny Prevedello, Professor, Department of Neurosurgery, Ohio State University, Director of Skull Base and Pituitary Center at the James Wexner Medical Center. Danny is Brazilian, grew up in Brazil, got his MD at the Federal University of Paraná. You can see actually the university in your top left. Did his residency with Dr. João Candido Arauja. I'm probably destroying the pronunciation. He will correct me later. At the hospital Nossa Senhora das Graças, or is it Graças? I don't know. Graças, correct. Did his fellowship, pituitary and epilepsy surgery. Look at his pedigree at UVA with Ed Laws, whose picture you can see there. From there, went on to Amin Kassam in the early days of the expansion of endoscopic surgery at UPMC. He did endoscopic and skull-based surgery with Amin, and has been at Ohio State University since 2010 with a huge name, of course, in ENT rhinology, Rick Carau. And he is there right now. And thank you, Danny, for joining us and defending the point for endonasal endoscopic surgery for anterior skull-based meningioma. The other speaker, my also excellent friend, Henry Schroeder, president of the International Federation of Neuroendoscopy this year, professor and chair at the University of Medicine, Greifswald Department of Neurosurgery. He was born and raised in Prenzlau in former East Germany, did his MD and residency at University of Medicine in Greifswald, has been there since as a resident and became a very young chair of that department in 2004. Of course, his clinical interests are everything endoscopic, whether it is intracranial, intraaxial, intraventricular, whether it's endoscope assisted, whether it's endoscopic skull base, endonasal. He and I share love of skiing. Here we were back in 2007 in Zermatt. So I'm not sure what is it between endoscopes. These are hanging endoscopes and hanging skis. There must be something that attracts endoscopists into skiing. We'll have to study that in a randomized trial on another day. So that's it. I'm delighted that this evening is shaping up the way it is. I'll stop sharing my slides, and Danny, I invite you to unmute your phone, your microphone, and start your presentation.
Thank you so much, Jacques. Just please confirm you can see my screen here.
I can, and yes, we see perfectly now.
Perfect. I just want to correct the name of my mentor, João Cândido Araújo. Yeah, he is my mentor from Brazil.
Thank you.
From Hospital Nacional das Graças, University Federal do Paraná. So thanks for showing that, because one of the things that I believe is that, that's my main tripod that I have, those three names you pointed out. And I like to mention that I think we follow people in life, and those are, as inside neurosurgery, those are the three three people, the three neurosurgeons that I follow and built my principles on top of that. So in terms of endoscopic skull-based surgery here for anterior skull-based meningiomas, I will share my philosophy here, and you will see, you know, although I have to have the mission to talk about really the endoscopic indication here, like I will show like when I see indication in the rare situations where I feel that the craniotomy is better. So put that way. So and then we'll debate afterwards. So some of the disclosures there. And so as a principle, the main advantage of coming endonasal is that really follows the principle of skull base, where you don't retract the brain to reach the entire anterior skull base. So from orbit to orbit, you have access to the entire skull base from the posterior aspect of the frontal sinus all the way to tuberculum sellae. And again, you don't touch the brain. So really follows the principle of skull base there as the main advantage of the endonasal approach. We work in a single cavity using by manual dissection, very important. I think in the early days when people tried to use the endoscope in one hand and the dissector in the other hand, that doesn't exist anymore. We do this with forehand technique where the surgeon dissecting uses both hands to take care and resect the tumor, and always with the dynamic visualization. So the endoscope goes in and out, and that helps with the 3D understanding of the depth perception in comparison to the position of the structures. So the beauty is that tumor like this, located in the anterior skull base, it basically get transformed into a convexity tumor, because we go with devascularized, we remove the bone. We can, for small tumors, even get a Simpson 1 in the resection of these tumors, because we remove the dura where the tumor was attached and then perform the reconstruction. And that's what I emphasize if the tumor is not very large. So it's very important to understand when to indicate endonasal, and I think that's what I'm gonna show over the time of this talk. Like I said, removing the ethmoidal arteries really help with the anterior skull-based meningiomas, particularly at the olfactory groove region. And if you have tumor more like a tuberculum cell, then removing the vessels of the dura, the meconal arteries that come from the carotid artery, also you can have an early devascularization. And then all the reconstruction here, we always going to perform a vascularized reconstruction, vascularized flap. So I want to point out this recent paper that Steve McGill published with the group from Naples and UCSF, McDermott. They put this together. Very nice paper. Steve McGill is my current fellow here. He had just started in July. Fabulous, doing great already 1 month with me. And you can tell that he's going to be a superstar. So they put this together and giving numbers to the tuberculum sellae meningioma. So the way I'm going to present here, I'm going to go from posterior close to the chiasm all the way to anterior. So with the tuberculum sellae meningiomas, I like this classification. So it takes in consideration the size of the tumor. I give you 1 point if it's less than 17, 2 points more than 17 millimeters. If it invades the canal or not, if it's not, doesn't get any point. If it invade one side, it will get 1 point. Two sides will get 2 points. And then the involvement of the anterior circulation. If it doesn't, so no points. And then 1 or 2 if it surrounds the vessel, as you can see in these pictures. So I look at our cases, and the reality is the majority of these cases that we do, they get like 4, 5, or 6 points on this classification. And we, as most of you participating here in the panel, and some of the participants are part of this study where we actually collected a multicentric data about tuberculum sellae meningioma. So from my own numbers, most of the tumors, most of the tuberculum sellae meningiomas that we do, I would indicate an endonasal approach for resection. If not the whole, if it really fulfills the definition of tuberculum sellae meningioma, very likely I'll be doing an endonasal surgery for resection. The main reason is for the most part, it's going to be under the chiasm. So the entire surgery, you have visualization of the entire undersurface of the optic nerves and the chiasm. The other reason, if it invades the canal, as you can see in these cases here, I can open the optic canals, and the medial aspect of the optic canal, we can remove the tumor from there. And as I pointed out earlier, we can always get a complete resection like this. yeah, if it's really a tuberculum cell meningioma, it's very likely that we'll be able to get a complete resection. The reason I say that is sometimes you have more complex tumors. If there's a part is peeling on top of the optic canal, then is a different story. That is not a complete, like what I would call tuberculum cell meningioma. And that is then other approaches will need to be designed. So case like this, this is like just to show here some examples. We perform the exposure. This is a case that is a good example to show the step-by-step the way we do. So we expose well the optic canal bilaterally. This is when I was doing, so the use of ICG. The ICG helps you to define the position of the carotid arteries on the approach, and also to see the blood supply. So after after kind of coagulating the blood supply there, then I perform the incision. So in terms of the way we do this, I always explore the upper part of the cella on top of the diaphragm. I don't open the superior intercavernous sinus in these cases because the cella environment usually doesn't have any tumor. I use a 90-degree Carrison to open the dura laterally. So that way I keep it this something that I never use on the bone. I only use to open dura. And I do that on the clivus as well. That's the way I open dura. Then I go down here below the tumor and I find the pituitary stalk first to know how deep is the tumor. And then after defining the pituitary stalk, then we rotate. I always tend to go first on the right side. And here's what I show: find the carotid, find the optic nerve, and then dissect the tumor from the rotating from the chiasm and then the other side. So here I use this aspirator cutter system as well, something that helps to debulk. And then I'm just going to show here at the very end of this. This is the way I open the canal here at the end of the procedure. So here you can see the optic canal is already drilled out because I knew it was there was invasion. I also have a knife that I designed that they can hook in this corner here. And then I go until I remove completely the tumor. You can see this is the right optic nerve, and we can clear that tumor there. If there is anterior skull base projection there, that's the way we remove the dura to remove all the insertions of the meningioma. If it is on top of the optic canals, that's a limitation that we cannot go there. And this is why it's very important, case by case, the way we plan this the indication. So here's one more example how we open the canal. This is a tumor that was kind of coming through the canal. So you can actually open this fillet open all the way from the cistern to the anole of zinc, and then clear the tumor away from the optic nerve. This is another, this is a small one here that we used, and it's not passing, it's all right. So here's an example, even larger tumors like this with a lateral implantation. This is a post-op and with reconstruction with the nasoseptal flap. So overall, like what I tell patients, our CSF leak is around 1 in 10. So I prepare patients, you know, to that high chance of going back to the operating room. It is one of the downsides of coming through the nose, and we all know that. Resection, complete resection, it's about 85 to 90% of the time. The cases in general that in my series that I wasn't able to get a complete resection, either because previously had a craniotomy and some scar present there, or because of lateral extension around the carotid artery, that it was not a completely tuberculum cell meningioma, it had like further extension. I have a couple cases where I wasn't able to preserve the superior hypophyseal artery, which I think is the most important aspect of this dissection laterally, and that's the main thing that I look for. These patients had some changes in the visual fields because of that, the superior hypophyseal arteries, and no mortality. So here's the picture of that superior hypophyseal that usually in tuberculum cell meningiomas is pushed laterally. And that's why I start the dissection, encounter the stalk, and then I move myself to the sides to encounter the superior hypophyseals and then dissect it from the optic nerves. So here's examples of cases that we've done, and here post-op. So when we look at the post-op MRI, we're always looking at the flap, make sure the flap enhances, and the pituitary gland enhancing means that we preserve that superior hypophyseal artery. Sometimes we face some larger tumors, a little bit of them bigger than a tuberculum cella with anterior skull base, plano already involved, going around the Sylvian fissure there. So this is a patient that I didn't think we would be able to remove completely endonasal. I actually is the first patient that I create this concept of going 2 stages, debulk endonasal, decompress the optics, wait, and then come back with a craniotomy. That was my plan for this patient. But then with the surgery here, we were, let me just go back, but we were able to dissect, the tumor was somewhat soft, and I was able to rotate from the bifurcation there. You can see the bifurcation. The optic nerve was really compromised, as you can see the anterior circulation by transference there, like through the optic nerve. And with a good exposure, bottom line, we were able actually to rotate that whole tumor out of there. We preserved the stalk here. You see the superior hypophyseal arteries there, and we were able to use by hand, by manual technique here, and get that whole tumor resected. You see the anterior circulation up there. So I learned a lot of this case, and we were able to get these out of there, improve some of the vision of the patient, never normalized because it was really compromised. But that shows the potential for these cases. And you see the pituitary gland enhancing and the stalk enhancing and the flap covering the skull base there. So every case is different, and this is what I remember, Jacques, once you gave a talk and said, small tumor, people will go this endonasal. This is a case that I looked carefully. Initially, I thought as well, like maybe endonasal would be great here, but this, if I move back and forth at the coronal, this is, as you can see, implants on top of the optic canal. It was very pneumatized, and it was invading the optic canal from the top, and by going back and forth, I saw the optic nerve was pushed down. So this is a case that I decided not to go endonasal because I didn't want to see the optic nerve first here. It's more like an anterior clinoid meningioma that was sitting on top of the medial aspect as well. So it's anterior clinoid meningioma that grew medial. So I did an eyebrow for this gentleman and got a complete resection with a small craniotomy. And I know Henry is going to talk more about that, but I want to show some balance as well and the importance of indication. If the tumor is in between the orbits and not spilling on top of the optic canals and doesn't touch the anterior circulation and comes all the way anteriorly, those are great cases. My main factor to indicate endonasal or not is the olfaction. If the olfaction is present, I may remove this with a craniotomy. And if the olfaction is already gone, and we test every patient with the 40 points upside test, and this is an example of a patient with some edema here, and the olfaction is gone. And in these cases, here's an example that we came endonasal, and then we tried, and then we resect the tumor if the olfaction is gone. This video that I'm showing here is actually a patient that I forced the indication where the tumor was more on the plano sphenoidale, immediately behind the tubercle, behind the olfactory groove. You see here the frontal polar that we have to dissect by manual dissection, exactly like we would do with the microsurgery. And in this case, patient had olfaction, but again, the tumor is located like posterior to the groove, so the olfactory groove. So we were able to get the tumor out of there. And if you look at here, this is the frontal lobe, gyrus rectus, and we dissect. There was some PA invasion, but here's the olfactory nerve preserved. So in this case, on the right side, the olfactory nerve was preserved, and we were able to actually preserve olfaction for tumors located. You see the olfaction right there, the olfactory nerve, olfactory tract. So for tumors in between the tuberculum cellae and posterior to the olfactory groove, we actually able to resect that tumor, preserving olfaction. If it is sitting on the olfactory groove, then we only do the surgery endonasal by going transcribiform if the olfaction is already gone. One of the main advantages of doing that way is this, that we published a couple of times, and there's some other papers now in the literature showing that you don't leave a big footprint in the brain. Basically, the flare changes that we call encephalomalacia, they actually get better. So this is that same patient. I can go back here, and you see here there was all this flare change, And we are used to see when, at least when I, like was doing craniotomies, I was seeing these flare changes getting bigger after surgery. And that's that footprint that we leave in encephalomalacia gets better with the endonasal. So I think that's one of the main advantages of push for this type of approach, particularly if the patient doesn't have olfaction anymore. Just a couple more examples and the way our philosophy. This is an example of a large tumor that located on the anterior skull base as well, and involving the anterior circulation completely, very large. I did this early in my career. I would do this differently these days. This I did endonasal in 2 stages. I did one endonasal, the bulk, and I came back a couple months later to take the rest of the tumor. So during that second stage, you can see here, let's see if I can, here, the key part is really to identify the optic nerves earlier. And because, with that, you can look for the anterior circulation, the A1s, on top of the tumor. And this tumor I was lucky here because it was somewhat soft, as you can see, but we were able to rotate away from the brain. This is I was really with the goal of complete resection, doing completely only endonasal surgery here. And then we went around. I'm gonna go ahead here and retract the tumor down, dissecting from the brain. And then, like, if you keep it going that way from anterior to posterior, then you get in trouble. So the main part was really identifying the chiasm, like there, and then looking for the anterior circulation vessels just above the chiasm there. And here you can see that's the A1s, A2s, and then we are dissecting the tumor away slowly and able to get that resected out of there, skeletonizing all the vessels. So we were able to do a very good job on the midline. I was very happy. He did great. He improved a lot. He had some frontal symptoms. And the reconstruction here we do with collagen matrix. We put some fat in the sphenoid, and then the nasoseptal flap covering everything. So he did very well, but I want you to show you this. And small residual at that time. And this 5 years later, it grew back. His still vision was normal, but in one point I said, I gotta go back with a craniotomy and complement what I did like 5 years ago. And that's what I did for him. And surgery went fine, but shows that, I left tumor behind. And I think if Ted Schwartz is on the panel, there was a few years ago, he actually called me, a patient that I did endonasal, and same thing. He said, Danny, like, your patient showed up in New York here now, and there's this side on top of the orbit, so you're getting recurrence there. And I think he did a craniotomy to do that. So it's not uncommon if the tumor is very large to leave residual on the sides. And this is something that Haydon Joe was pointed out many years ago. Like he said, it have that Fuji implantation laterally, like you're not gonna be able to cure the patient with endonasal. So in general, if I see the lateral extension on top of the optic nerve and this patient had normal smell, then I would not go for endonasal. This I did an eyebrow here, incision, and a complete resection coming with a small craniotomy, right frontal there. I try to avoid the side of the edema if possible. Of course, I was giving preference to the right side. And if it is on the left, then I prefer to take the orbit away, like take the rim of the orbit to get less retraction and more exposure on the left side. So one would say, okay, so maybe craniotomy is the solution all the time. And then you see this patient had this large tumor. Another neurosurgeon that was here at Ohio State in the early days performed a bicoronal, bifrontal, got this tumor out. Did a good job, a little bit of more encephalomalacia, but no really major DWI, just a little bit here and there. The problem, this patient lost follow-up. And if you look at here, there was no enhancement mass residual, but all the hyperostosis was left behind. And this hyperostosis now grew into this, and this patient showed up in my clinic losing vision. You can see here the signs of the bicoronal, big craniotomy done in the past. And that's the tumor that was showed up, and she was really losing vision badly. So in this case, what I did is the opposite. I came endonasal now to complement the surgery that was done 10 years before. And then that's what we accomplished here. We're able to get that nicely resected with the compression of the optics for this lady, just, basically complement the surgery from years before. So what I learned with this is that for these large anterior skull-based meningiomas, when you see a lot of hyperostosis and lateral implantation, I'm not going to force endonasal here. And I do think if you go with a craniotomy, you're probably going to leave something behind as well, or you may end up creating a big chance of a leakage as well. So it's, I think the bottom line for the large tumors, I believe they are complementary. So what I've been doing now for the last, I would say 4 or 5 years, for these tumors, I drill the hyperostosis, I take the anterior and posterior ethmoidal arteries, devascularize the tumor. This is before surgery, very red, with edema on the brain, and then I make a hole on this tumor, and this is the MRI later after the surgery. So I try not to dissect in the plane in between the brain and tumor to avoid creating a scar and that region. And you can see this is a devascularized tumor. It collapses, the edema gets better, and then I perform instead of a large craniotomy, I come with a small frontolateral craniotomy without even the need for any retraction. And we were able then to get this tumor with a complementation basically of the craniotomy. You see the optic canal here. The flap was used in the first surgery to close the skull base, optic canal on the other side. And this is soft, it's very interesting. You can bipolar there, remove all the implantation, get a complete resection of the tumor, and all the hyperostosis is already drilled in stage 1, and you get the flap there. The closest that I've done one surgery to the other is 2 months, and the further away is about a year that I did second stage. And you don't want to wait a year. I thought that the tumor was growing back. And was the only reason we did a year because the patient had cancer newly diagnosed at that time of the first stage. So we let the patient to focus on cancer. He got actually what he called cured of the cancer on his lungs, and then he came back for stage 2 a year later. But in general, I prefer to wait about 3-4 months and then do the second stage. Here's, you see, a small craniotomy, right frontal orbital, I call there, just anterior, basically focus on the anterior skull base, flap still in place. I've done, I think, 9 of these cases. My partner, Dr. Doug Hardesty, is about to do another combination of these as well, with the 2 stages. And I never had a leakage of fluid on any of these cases. So with this, Jacques, I think I finish in time. I want to invite all, hopefully we'll be able to offer this. We're planning to end of April of next year to have our course. The next in ASBS, we're still, still questioning what we're gonna do. For now, it's still scheduled for the second week of February in Atlanta. We'd like to invite everybody. So this date may change, it may go virtual, it's still under discussion. But I'm still hoping that we can have that meeting there, because like we were saying earlier, this is the best meeting that we meet all our friends, and we're always great to be together. So thank you so much, and I'm looking forward to the discussion.
Great, thank you so much, Danny. If you could stop sharing, that would be great.
I did.
Excellent. Yeah. Henry, if Henry has not fallen asleep on German time.
Still sleeping, yes.
Excellent. Why don't you share your slides and tell us why Danny is completely wrong in his approach? Or maybe not. Very nice talk, Danny.
Can you see it?
Yes, it's in navigation mode. Just click, play to, yeah, perfect.
To bring this away. So Jack, thank you for letting me be part of your nice initiative to have these webinars to compensate for the lack of physical meetings. Of course, I would like to have a beer with you face to face, but that is an alternative at least. So my topic is anterior skull-based meningiomas. Transcranial corridor is ideal, and I hope I will convince everybody that Danny is wrong and the transcranial approach is much better. There's a lot of debate in the last time. Is endonasal better? Is transcranial better? And I agree, there are some indications where the endonasal route is much better. For example, for craniopharyngiomas, usually the craniopharyngiomas cause the prefix chiasm, they push the chiasm anteriorly, and then you have a bad access. But the tuberculum meningiomas, for example, they push the chiasm backwards. We have a post-fixed chiasm, and then we have plenty of space. And if you look at most of the review articles or meta-analysis, they always found that the open transcranial approach has a better rate of gross-total resection and a lower rate of CSF leakage. But in the tuberculum celli meningiomas, we have a better visual improvement rate, but still CSF leakage is significantly higher in the endonasal surgeries. And there was a nice review from Ted Schwartz, and he said what is very important for well-selected tumors, the endonasal route has a better visual improvement rate. That is, I think, very important for selected cases. The endonasal approach is really nice. So what effect is influencing the approach? Of course, tumor location, tumor size, brain invasion, vessel encasement. And for me, it's very important is the individual skull-based anatomy. For me, the selection of the approach frequently depends on the skull-based anatomy. For example, is there a very steep tuberculum celli? And of course, surgeons' preference and experience is an important factor. So then he mentioned already the pros for the endonasal approach: no brain retraction, early devascularization of the tumor, less manipulation of neurovascular structures, and early optic nerve decompression. But there are a lot of cons. And the major problem for me in the anterior skull-based meningiomas is that you have a very limited overview of the skull base. You just see the center. And everybody of you knows that the meningiomas have frequently an unplugged growth laterally to the tumor, which is visible on the MR image. And this will easily be missed from the endonasal route. You have less control of neurovascular structures. If you have a hemorrhage, from the transcranial approach, you can place 2 clips, you can make a suture and preserve the vessels. When you come from endonasal, it's much more difficult. And although we have improvement with the skull-based reconstruction techniques, there is still a significant higher CSF leakage rate. And we should not forget, last but not least, that the prolonged nasal care is required. And our ENT is following the patients, and sometimes we have patients which require at least 4, 5, or 6 months until the mucosa has really a good healing. So in my department, we just use 3 approaches for frontal skull-based meningiomas. This is a frontolateral approach, the superorbital, which is just a minor version of the frontolateral, and the endonasal approach. I think everybody's agreeing that sphenoid wing meningiomas are clearly an indication for transcranial. Smaller tumors are approached via an eyebrow, the larger tumors via frontolateral approach. Olfactory groove meningiomas are more controversial, as Danny has already mentioned. There's one report from the Pittsburgh group. I admit that it's an early experience published in 2014, but if you look at the results, you will see it is a difficult procedure, 30% CSF leakage rate with revisions, staged approach in 18 patients, length of surgery very long, 9 hours, gross total resection rate just 67%, and loss of affection in all cases. And in my opinion, these are unacceptable results. Then he made a nice point that because of the avoidance of any brain retraction, he had a lower rate of flare changes, but still 30% leakage rate at that time. Jim Liu made a nice comparison between transbasal transcranial approach and an endoscopic endonasal approach, and he found that he has a much better resection rate and lower complication with a transcranial approach. But if you see on the exposure, this to me is a little bit too much for a meningioma. We use this approach for malignancies, but I think for meningiomas it's not required to have such an invasive skull-based approach. And then the paper of Ted Schwartz, he found that he had only 50% gross total resection rate in his endonasal cases, but 100% with the superorbital eyebrow approach. And of course, then he has to reply to this publication and JNS, and then he said that they think the endonasal approach is still worthwhile to do in many patients. And he offered his concept to have a 2-stage procedure, first devascularization endonasally, and then come again and resect the tumor transcranially or endonasally. When I see this kind of patient, I think it's not required to have a two-stage surgery. If this is an employed patient, he asks you to have a solution for his problem in a single stage. He does not want to leave the work 2 times. And I think if it's possible with the same clinical outcome, then we should make it with a single stage surgery. And what Danny mentioned, that there was a recurrence because some of the surgeons left here the hyperostosis, then I think it was a mistake by the first surgeon, because all of the invaded bone can be resected from a transcranial approach, of course. So with this kind of tumor, we would advise for unilateral frontolateral approach. Very important is that you have the right positioning of the patient. So the body should be 15 degrees up, and there should be a hyperextension of the neck, that the zygoma is the highest point. Then the skin incision is behind the hairline. We make a small craniotomy. It is very important that it is flush with the skull base to avoid retraction of the brain. The first step is, of course, opening of the sylvian fissure, release some of CSF. And there's no need for any retraction, as Danny pointed out. You make a quick debulking of the tumor, and then you have a good option for by manual dissection of the erectoid plane here. You see the tumor. This is the right optic nerve. This is the left optic nerve. You have a very good overview, and you can dissect with the traction, counter-traction technique, try to preserve the arachnoid as much as it is present. And you see now the hyperostosis can be taken from transcranially in the same way you do it endonasally, so there's no difference. We can also remove tumor from the inside of the ethmoid cells from this approach. It's no problem. And then we have the good option, we can harvest a lot of autologous material to have a good skull base reconstruction. So the CSF leakage rate is less, even if you have an aggressive resection of the skull base in these cases. And the cosmetic result is also not too bad. You see very early we have a good recovery of the visual field, and we always make a T2 weighted image early after surgery, usually the next day, to see is there additional trauma. And I think there is not much of the trauma. If you avoid to put a retractor in and retract the vein, but use dynamic retraction and correct positioning of the patient, release of CSF, then I think there is not much additional damage, even in these large tumors which present with edema. And this is after surgery. You see the edema also resolved to a certain extent, and the cosmetic result, even with this old-fashioned incision behind the hairline, is not too bad if you handle the tumor, if you handle the muscles, the temporal muscles carefully. Also for these tumors, what is the approach? There's no need to make a bifrontal. It's just unilateral frontolateral approach. If we have intact olfaction, of course, we want to preserve olfaction. That is very important. When I was a resident, I was thought it's no problem. You just simply cut the olfactory tract. It's not important. But if you love red wine like me, or you work as a cook or so, you need good olfaction. It's a very important sense. And this lady, we offered the surgery to be an eyebrow approach or a frontolateral with incision behind the hairline, and she selected incision behind the hairline. And you see, there is a problem to go to the olfactory groove, but we can use a 30-degree endoscope to look deep down into the groove and the button of the groove, and here we can dissect the tumor, which is located under the olfactory tract. So I think we can get a very good resection with preservation of olfaction. Of course, I would not term this a gross total resection Simpson grade 1 because we leave the dura, but our experience has shown that the recurrence rate, if you resect the tumor in that way, is very low, although there are some tumor cells in the invaded dura around the optic nerve. So I think preservation of olfaction, I think it's very important, and it's possible very easily with a transcranial approach in many cases. Most of the result, if you handle the muscle, it's okay. So the argument that endonasal is cosmetically so much better, I think is also not very valid. If you see this small tumor, and we show it in our courses, many people say, yes, this is for endonasal. You see the tumor is only on one side in the frontal part of the olfactory groove. And people say we make a unilateral approach, but then in the back, it's crossing the midline. So I think there is a risk that you leave some tumor behind. The supraorbital approach is ideal. The positioning is the same like for the frontolateral approach. The body goes up 10 to 15 degrees, hyperextension of the neck. Zygoma should be the highest points and the frontal lobe falls back by gravity. Incision exactly within the eyebrow. It's very important to drill the inner margin of the craniotomy and also the bumps on the orbital roof to have a good view to the skull base. So the height of the craniotomy should be around 2 centimeters. And it's very important, again, release CSF, give time for the brain to fall back without any retraction, and then you can have a nice resection without damaging the frontal lobe. So another patient came in with this lesion, incidental finding, olfaction still good. So we made an eyebrow approach. We preserved the right olfactory tract, preserved the left olfactory tract, and you see the frontal lobe looks good, so no damage to the frontal lobe from retraction. And especially in patients with a bald head, the eyebrow incision is really ideal and gives usually an excellent result. And here's his sense of smell, and he sees only a little bit deterioration after surgery. The endonasal approach has also value, of course. If we have a tumor, like here, this is a recurrent tumor occurring only in the nose after transcranial resection at another institution, complete loss of olfaction in this patient. Of course, this is a good indication for an endonasal approach, but it can happen that you have a problem with wound healing, especially if the flap is hardly reaching the anterior part of the skull base, like in this case we did. So we had the development of a brain abscess, what we have never seen in our transcranial series. So when I look at my last 25 patients with olfactory groove meningiomas, I had 16 patients with at least hyposmia, and in 13 of them I could preserve the sense of smell in at least one side. So for me, in most olfactory groove meningiomas, the transcranial approach is really the better choice. Tuberculum celli meningioma is another story. This was one patient presenting with really a tunnel view and bad visual acuity. The tumor goes into the cellar, and when we discuss this case in our courses, many people say, yes, it's for endonasal. But if you look here, it's like a mushroom. The intercarotid distance is very narrow. And what concerned me most is that the chiasm is very thin over the tumor. So I was afraid if this chiasm is sticky to the tumor and I pull on the tumor to get it out, that I do some additional damage. That's why I choose an eyebrow approach. First step is to opening the falciform ligament and then devascularization of the tumor. I tried to use ultrasonic aspiration in this tumor, but it was very fibrotic and I could not take it out. And you see here now, the chiasm is very sticky to the tumor. And because it's a post-fixed chiasm, I can gently dissect all these small vessels, which are very important for a good visual outcome from the tumor. And I thought from this approach, I can do that in a better way than from endonasal. So the endoscopic inspection shows then that the tumor is really coming like a mushroom from the cavernous sinus, from the intracellular space. You see this is the pituitary stalk here. This is the grooving on the optic chiasm, and I open the diaphragma celli under microscopic view, and then I could remove the tumor also from the cellular space. So the eyebrow for tuberculum celli meningiomas, I think, is a very good option. You see the visual improvement already after 3 days, and cosmetic result usually is really nice. The cosmesis of the eyebrow approach is good, but I strongly recommend that you fill the gap created by the craniotome with bone cement, especially in ladies with very thin scalp. You can see the outline of the craniotomy when the scar is formed and the shrinking of the scar is occurring. So you have to fill it with bone cement in that way, and then usually you have a very nice cosmetic outcome. It's ideal for patients with a bald head, but also for ladies with very thin eyebrow. You see, after 3 months, it's hard to see the incision. So I think from the cosmetic point of view, the eyebrow incision is really a very good option. Of course, there is also an indication for endonasal approaches. This was a nice Korean study, and they showed cases with a higher rising tumor and a low-lying tumor. And of course, if you have this configuration of the tuberculum celli, such a steep tuberculum, then it makes no sense to come from transcranial. Then I think it's much better you go endonasal to take this lesion out. So there are indications, of course, for an endonasal approach. This was one of our cases. The tuberculum celli is quite steep. Tumor goes down to the pituitary gland, and then we open it. You have a nice devascularization of the tumor very early. And if you have this nice arachnoid plane, of course, it's a very nice dissection. The problem is you cannot predict how is the plane of the tumor to the surrounding structures. That's why I think in most of the cases, I still prefer a transcranial approach. We have to be careful because sometimes you have findings which are really difficult to handle. So when you see this tumor, you can say, okay, endonasal is an option, transcranial is an option. The tumor is extending to the right optic canal, but not to the left one. So if we have a unilateral optic canal invasion, I always come from the contralateral side because then I have a direct view into the canal without using an endoscope. So in this case, we come from the left side, frontolateral approach. And initially in the procedure, I don't coagulate much just to get an overview. And I was very lucky that I did this in this case because here you see this is the carotid artery on the right side and on the left side. And you see here on the right side here, you see the tumor going into the tumor. And this artery goes really in between the tumor lobules. And I think it would be very difficult to handle this vessel from an endonasal approach. Of course, it's possible. When you see it in time and you don't damage it with the grasping forceps, then it can be done. But I think it's much more difficult because you see it's very much involved with the arachnoid and it's in between the tumor. So I took a long time to dissect it. Fortunately, there was a good arachnoid plane enabling the dissection of this vessel from the tumor surface. The arachnoid is very well preserved and I could take it out. And in this patient, there was an anomaly. There was just one vessel of the superior hypophyseal artery, which is supplying the whole chiasm. See, this is a vessel, very thick vessel, and it's the only one. You can imagine if you damage this vessel during the surgery, then the patient has really a visual problem. There's another patient, you see tumor seems to be midline, very well delineated, should be a good case also for endonasal. But when we open the dura, you see the tumor has unplugged row, which could not be expected from the MRI. It goes over the optic nerve and over the carotid. And these are the tumor parts which can be easily missed in meningiomas. That's why I think with a transcranial approach, you always see this extension, which is hidden for the endonasal approach. Another argument for a transcranial surgery. It's another patient, decreased visual activity on both eyes. If you look at the MRI, you see there is the anterior cerebral artery complex close to the tumor, but it's hard to say, is there an arachnoid plane or not? You don't know. You only see it when you open. And here in this case, you see there was complete infiltration of the adventitia of the anterior cerebral arteries on both sides and also of the ACOM. And it was very difficult to dissect the vessel away from the tumor. And if you want to do that from endonasal, again, it is possible, but it's much more difficult and much more risky. If you have a hemorrhage from this vessel, you cannot deal it in the same way which I could do from a transcranial approach. And then there was a nice paper in 2018 from Ted Schwartz about the comparison of endonasal endoscopic surgery and transcranial surgery for tuberculum celli meningiomas. And they reported a 44% deterioration rate after transcranial surgery compared to 0% in the endonasal. And they have a high, very high rate of post-op seizures after transcranial surgery. And in the same issue, we had our experience with 15 cases and we had no seizures. and we had an improvement of visual acuity in 90% and no deterioration. And of course, I had to write a letter to the editor because it is in the same issue, and I presented my thoughts about the benefits of transcranial surgery. And then Ted, of course, replied that any meta-analysis ever published comparing endonasal to transcranial surgery leads to a better visual outcome in the endonasal route. Then he was citing his own paper. Then when you look at his paper, which was published in Working with Surgery, he compared the visual outcome, and then he stated there were no significant differences in visual outcome between these groups. So I think there might be a problem with visual preservation of the vision, but usually it is a matter of growth of the tumor. It's not so much the approach. This is my current series of tuberculum cell meningiomas. I have 2 visual worsenings on one eye, but in most cases improved vision, preservation of olfaction in all cases, just 1 CSF fistula which required revision, and 1 subgaleal CSF accumulation which was treated with a lumbar drain, and no infection. The visual deterioration, the problem is if the tumor is sticky to the skull base below the ipsilateral optic nerve, because this is a blind angle, and if you retract the nerve, of course you may cause damage. But you can use an endoscope also in transcranial cases, and you look under the ipsilateral optic nerve and you see tumor remnants which are here, and you can dissect them under direct view. There might be a major problem which is related to the tumor itself. So this was a lady from Cairo, and you see this tumor, tuberculum cell meningioma, and you see there is some calcification. So it looks ugly from the beginning, and when we tried to dissect it, we found that there was no arachnoid plane to the chiasm, and that was a problem. You see here, these are the branches of the suprahypophyseal artery, and they are really completely invaded by the tumor. Initially, I thought to stop the surgery because I was afraid to make her blind when I sacrificed both hypophyseal arteries on both sides. But then I started to dissect, and it took me 10 hours to dissect this vessel, which was very sticky to the tumor, away from the tumor. And finally, we could decompress. But it was a matter of tumor growth. It was not the approach. It's the problem is if the tumor is invading and has no plane to the chiasm, of course, there's a high risk to get a visual deterioration. And you see on the left side, she has a visual field problem. Fortunately, after 3 months, it improved. And you see here, quite good resection. And this after 3 months, you see improvement of the visual field. So the growth pattern of the tumor, I think, is a major problem. So when I conclude, my philosophy is for olfactory groove meningioma, usually I prefer a transcranial route. The only exception if the major part of the tumor is located endonasally and the patient has already lost olfaction, then I come from endonasal. Planum sphenoidal is so easy transcranial. Tuberculum celli, usually transcranial, but if I have a very steep tuberculum and I have really a midline lesion, or sometimes the patient is requesting to have an endonasal surgery, and I think it's possible without risk, then I choose an endonasal approach. But most of them transcranial, and medial sphenoid wing, I think is no question transcranial. So my conclusion is, for most anterior skull-base meningiomas, the transcranial approach is still the better option because we can overlook the entire skull base, we can see each corner, and we have a good control of the vascular structures around. Of course, it's an individual patient-based decision, and there are, of course, indications also for endonasal. I agree with that completely. So, Jack, it was nice to see you physically. I hope we meet somewhere again to improve our skiing abilities, and I hope we have soon a beer together. Thank you again for the invitation to this nice webinar.
Thanks very much. You're making me remember good times. Thank you. Very clear talk. Thank you, Henry, very much. I think we can stop. Yes, thank you for stop sharing the slides, and I'll invite Ian Dunn to begin his presentation. And again, for the audience, thank you for sending your questions into the Q&A box. And after the panelists, we will address most, at least, of these questions. Ian, unmute yourself, and right now you're on double slide projection. Yes, that works. Are you muted? Yeah, unmute your microphone. There you go.
There's one in every group. I did it about a half an hour ago. Jack, thanks for asking me to be part of the panel, and it's an honor to be on the panel with everybody here. And those are two spectacular talks. Greetings from Oklahoma. I don't know if anyone knows too much about us, but we're really into animal preservation here. And you may have seen some of us in the on Netflix recently.
I'm not sure, is this show very international or is it mostly US? I'm not sure if our international audience know who you're talking about.
Well, you can Google Tiger King and you'll learn all about this great state of Oklahoma.
Exactly.
Just one disclosure. So here's a case I did recently, and Jacques, I think you asked us to show a few cases, and I'm going to do that, and hopefully weave in, I think, recapitulate some of the points that Danny and Professor Schroeder made, and then add a couple of other points too. So this is a 42-year-old woman with bilateral visual loss, right greater than left, 2080 on the right and 2040 on the left. So I think, not the biggest tumor we see, but I think, generally in the run of play, it's something we see in clinic each week. I think there are some radiologic features that will mimic what some of the other speakers just showed. So unclear relationship with the anterior cerebrals if you look at the bottom left picture here, and clear thinning and displacement of the chiasm as expected, and some element of calcification. Unclear from the pre-op if that's just simomatous elements or true calcification. I think all of us try and infer tumor consistency from our imaging. I know it's imperfect. You'd say here it's slightly T2 bright, but the CT shows some elements of calcification, so they may cancel each other out. So hard to say what that consistency is. And I think consistency certainly matters both from a transcranial and intranasal route. So intranasal or the eyes are concealed to conceal the nature of this patient. But do you make the incision, behind the hairline or at the eyebrow? I favored in this particular case a superorbital. Now, when I say superorbital, unlike other speakers, it's a incision behind the hairline, and it's a one-piece cranioorbital flap. So it's a small frontal craniotomy with the orbital rim in one piece, and you can see this is the right side, the periorbita on the exposed here. Not a long exposure. That's one of the I think often cited cons of that approach. It's about a 30-35 minute exposure, but just going to show a little bit of this video here. And like other speakers, I just make a low transverse incision in the frontal area here. Not that you need the orbit off to see this, but when you have the orbit off, you're just right down on the base immediately. Olfactory tract right displaced by the suction, no retractor as the other speakers have shown. They need to unfurl that arachnoid plane. You see that attenuated optic nerve on the right side, and you're getting to know the tumor. This is a wide Fisher split, I think, for this case with the unclear affiliation with the ACAs. Again, you can see these simomatous elements as, again, you're getting to know the tumor, you're getting to understand what its affiliation and insinuation with neighboring tissues is going to be. I want to see what those perforators look like. So expectedly, you see them to the left of A1. So we're going to be working underneath this side and bring the tumor down for the remainder of the case. What's that arachnoid plane going to be like? It's not your beautiful plane that's going to come right off. So here you see another perforator, and very quickly, as Professor Schroeder said, you're gonna need bimanual dissection, not just with suction and microbayonet. I'll show here in a second, but likely with two hands using microdissection, and that emphasizes the importance of your assistant. We're going to debulk here. I think someone mentioned here we have 2 microbayonets providing better biometric control. possibly an advantage in a sticky erectile situation like this is shorter instruments and greater physical leverage to exert these forces of traction and countertraction. You need a really good assistant here to be able to do a little bit of suctioning for you, and all of you probably appreciate a good assistant as well. But I think an advantage is short instruments controlled by manual microdissection. You can see here now the left optic nerve as well. And once the bulk of the tumor is out, as many of you appreciate, that's when phase 2 of the operation starts. So the vascular structures are intact, neural structures are intact, but now it's a little bit blurry there. But now it's the involved dura, the offending bone, and the optic canal. So all of that, just as it is with an endonasal approach, is attackable and achievable through a transcranial approach. So drilling the involved tuberculum, involved clivus, and opening up both the left and the right optic canals, which you can certainly do medially endonasally, but obviously laterally and medially through a transcranial approach. Just a few more seconds here, but you can see the pituitary stalk will come into view here in a second. Here's a stalk right there, and again, you can achieve a complete resection in this way. So, what influenced my choice of a and this dura comes together nicely here. Transcranial route was, I thought, the unclear affiliation with the ACAs and the perceived firm consistency that required, in the end, a sonopet for part of the operation. And so this is a coronal flare, so no increased flare signal, as some of the other speakers have mentioned. This is a grade 1 meningioma, the KS67 of less than 1%. I'm gonna make one nerdy science comment at the end of my comments here, so not to belabor the point. But we had we call this essentially grade 1 resection. This I did a couple of years ago, which was referred for endonasal surgery, but unclear where the extension would be. And I think Professor Schroeder made this comment here. This is I attacked this through a superorbital approach. You can see the right optic nerve here. Again, the MRI doesn't tell the story. You've got this on-plaque stippling of tumor lateral to the optic nerve. And a nice soft tumor, you can achieve a full decompression or removal of heparocytic bone, take the clinoid, and you can remove the offending involved dura. Certainly not the bulk of the tumor, and it may not show up on the MRI if you don't remove it, but you know it's there, and possibly susceptible to regrowth or recurrence. You can see the ophthalmic artery here. So slightly different approach than the other speakers. I like this. This is a larger version of the exposure, but small superorbital craniotomy with based at this Myocardius keyhole. I really like that approach with a one-piece flap, pericranial flap, which doesn't have to be harvested, but respected. Sort of a small subfascialized section of temporalis doesn't have to all be mobilized. Fissure access if necessary. Meticulous preservation of the olfactory tracts and the cosmesis of the frontal bone. And this is what I mean by the pericranial, respecting the pericranial flap. It's not harvested, but if you get in, you can remove all of that involved planum or tuberculum, and if you get into the sinus, which is no big deal, you have a vascularized flap at your disposal. This has been alluded to before. Approach limitations. You've got this on-plaque extension which you can't see. And I'll get to in a second why that actually may not be important, and this is just for philosophy and for some debate, not for not a hard stance. But this was just mentioned before. There's a blind spot underneath, I think, that ipsilateral optic nerve. Now you can see with the endoscope and so forth, but in terms of direct visualization, that is I think a blind spot there. I just want to allude to a point that we know more now about meningioma than ever, and we're really talking about how to attack the lesion. But in terms of understanding the enemy, we know that meningiomas feature a tremendously broad range of disruption of the normal chromosomal complement, and it's fairly well established. It will likely be part of the World Health Organization grading scheme in the future, that the number of these chromosomal alterations, that is how different the tumor cell is than a normal cell, associates with a recurrence. And what's really interesting about the tumors we're talking about right now, I'll just leave you with this thought, is that tumors that occur at the planum, these ventral midline, tuberculum, clinoid, really have very few chromosomal alterations. And so, versus the ones that are near the venous structures and midline and so forth. And so you wonder if we really are seeing the true measure of regrowth or growth of small unplaqued remnants that are left laterally, although Danny alluded to a couple of cases before. And these tumors are likely to occur less frequently and to be much more indolent than counterparts at other locations in the skull base and convexity. Thank you.
Thanks, Ian. That's fantastic. Speakers, any comments on Ian's presentation? Danny, anything you'd like to argue with, debate, or whatever?
No, I mean, great, quick presentation from Ian. And one thing that I would like to mention that I really liked seeing, because I thought I was the only one that still do, I called it Dr. James modified OZ, you know, and with the anytime I don't need to go to the temporal fossa and I want to remove the orbital rim, I do exactly like Ian does, like just that one piece and a little crack of the roof of the orbit. I don't know, do you do the crack as well, Ian, or you try to drill from the side? Because
you know, we all have these things that happen in our careers that sort of scar you forever. And one of those was doing the crack when I was a fellow with Dr. El-Mefdi. And the resulting reaction, I think, has sort of made me not do the cracks.
Gotcha. So
I can say that.
I never had a problem. I still do. I don't do very frequently, but when I do, I use with the crack. And I learned directly from Dr. Jane. I remember him saying, like, next to me, like, "Go, Danny, go, do it." You know, he was really an interesting man. That's when he described. I think that this was in 1983. I think when he published that technique.
Yeah, long time ago. Yes, indeed. Okay, Gerardo, unmute your microphone and share your slides, please. And Ted Schwartz, thanks a lot for joining us. Glad you could make it. I will.
I was deep in the third ventricle a few minutes ago, but I managed to escape. So.
Okay, thank you. Glad you made it.
So thank you very much, Jakes, for the invitation. It's a great honor for me to be here in this panel. And congratulations of both presenters, outstanding cases. So I want to share with you this interesting case. This is
Gerardo, by the way, not to interrupt you, don't tell us what you did. Just ask their opinion, how they would handle it, then tell us.
Yes, okay. 47-year-old female patient that that's very important. Is a well-recognized ophthalmologist here in Mexico. And she had a clinical course of 3 months, was dominated by the visual deficit on the right eye, only on the right eye. This is the campimetry of the patient. As you can see here, there is only a slight problems in the upper field of the right eye. So this is the MRI. You see here, this is a small, very small tumor here. Actually, is the smallest tumor, tuberculum cell meningioma that I have seen in my life. See how this tumor is located between the optic nerve and the pituitary gland here. So in the coronal view, it's possible to see the tumor is pushing the optic nerve, the right optic nerve up, and the carotid artery is in contact with the tumor. And you see the pituitary stalk here and the pituitary gland. And also, she also had a small microadenoma, non-functioning microadenoma. So this is the axial view. You see how the tumor is beneath the right optic nerve, and in the coronal view in T2, it's possible to see how the tumor is pushing the nerve, and it's in contact with the carotid artery. So I put this case to the panelists to give me some option that what would you do in these cases. So observation, of course, is not an option because the patient is losing her vision and is, of course, very worried about losing her vision. Remember, she's an ophthalmologist and is very, very terrifying with this situation. And tumor removal, of course, is the option. And there are, of course, 2 possibilities to remove the tumor. Endonasal endoscopic, that I'm sure Dr. Prevedello is going to be part of it. But we have some problems here, as in my point of view. So it's a very narrow space for working between the optic nerve, the pituitary gland, pituitary stalk, and the carotid artery. And also the ICA control, I don't see, well, it's not well seen in the MRI if it's there a real invasion of the adventitia of this vessel. And of course, the water-like closure, unless in my opinion, is difficult in this narrow space. So I think Dr. Schroeder is going to support the craniotomy. Which kind of approach would you use? I heard that the contralateral approach is better for you, and I want to hear your comments about this. And of course, the implant removal, do you drill the optic canal? Do you open the falciform ligament in terms of getting a Simpson grade 1 resection of the tumor? But again, there is some problems with watertight dural closure in this case. So I want to hear your opinions.
I would send for gamma knife.
Hey, Gerardo,
I didn't even put this option here, but of course it's totally short.
Can you show the coronal view
imaging again? Yeah,
okay.
The imaging will be helpful.
Which projection we want? Frontal, coronal, sagittal?
Probably the coronal GAD, I think, because I was going to ask you, they probably will want to know the axial GAD that's through the optic canal. Did you think there was tumor in the canal or just?
No, there was no any evidence of tumor invading the canal.
So please, sagittal again?
Sagittal, okay.
He wants to see how deep is the cella, is his secret.
Yeah, I think this I really would opt for the endonasal.
Yes, that's what I'm talking about.
Danny, I think you see, there's very steep.
Now we're done.
Seems to go down into the cellar space, and you see it on the left side. Then I think that is ideal for endonasal. Probably.
No, remember there's a pituitary adenoma. Henry, he said there is a pituitary adenoma.
It's a non-functioning pituitary microadenoma. There is no indication for surgery of that particular tumor.
No, but if you are there, you can take it. It's no problem. So it gives you some space. Yeah. But this, because it's a very steep tuberculum cellae, it goes down. I think I would take it from endonasal. I think it's enough space, and the tumor is located under the optic nerve. So in this situation, I would opt for an endonasal. Also, the chiasm is not pushed backwards. If you have a larger tumor, usually the chiasm is pushed backwards, you get more space. Of course, you can make also an eyebrow incision for this one, but I would opt for endonasal.
Yeah, I agree with Henry. If you look at the sagittal you have there, Gerardo, like the floor of the anterior skull base goes in plane with the upper part of the tumor. So that's what he meant. The entire tumor is below the plane of the anterior skull base. So endonasal is better. The disease doesn't go beyond the optic canal or the carotid. If you go back to the coronal, I like to look at that coronal to make sure that the indication and the other thing in your coronal that you showed is in T2, and the tumor also seems quite bright in T2. So that's it's something to take in consideration. See, it goes a little bit around the carotid here, but it's all medial from the carotid. It doesn't surround the carotid artery right there. Then T2 seems to be something that you would open the dura all the way to the carotid and the optic canal on the right side. I usually open a little bit of the optic canal just to make sure there's nothing there. And I would do this endonasal, no question.
Are you worried about the watertight closing of the dura mater?
Well, that's what I mean. We always, I don't know if the worried is the word, but we always paying attention on that. So we'll do our traditional closure with the collagen matrix, followed by the nasoseptal flap. And you know, I'm doing something there, like I learned from Schwartz here on the call. On the webinar, the use of gasket. So I do what I call now the soft gasket. So I don't use a material like a bone or a structure to push the first layer of the reconstruction. But what I do, I put Duragene and I use gel foam inside or more Duragene like a plug, and then it expands like a gasket, having but all soft. So I call the soft gasket and followed by the flap. And I think we reduce our CSF leak here. I look at my numbers, it's not significant. That's why I didn't publish that yet, but we may show that there is a tendency for improvement of our CSF leak using that technique as is right now. So that's what I would do.
Ian Dunn, how would you handle this case?
Sorry, I had to step away for a second.
Okay.
Yeah, no, I for all the reasons above, I would actually do this intranasally also. All of it's below most of it's below the anterior fossa floor. So I think that'd be a good indication for intranasal here.
Yeah, you know, Gerardo, when you looked at that axial with contrast, it does look like there is tumor that goes into the canal, both medial and inferior.
No.
And I think the endoscopic would be perfect for that. I mean, we've closed all these using Ted's model, using gasket seal closures, and it is a great way to close these things. You walk out watertight. We've not had any leaks using that kind of closure technique. You see that stippling that kind of goes anteriorly there? I think that is, and then the endoscopic approach gives you that perfect access to that.
Okay. Well, time running. I'm going to tell you what I did. Of course, I did the other side of the coin. I'm not an expert endoscopic surgeon, so I did a regular arterional approach, right side regular arterional approach. I prefer to have the carotid artery, ipsilateral carotid artery, close to me in case of some accident. Of course, I recognize that if we enter for the other side, a better control of the tumor, but I don't have enough control of the ipsilateral carotid artery. And very fast, this is the surgery. You see, is a small opening of the sylvian fissure. This is the optic nerve, and the carotid artery is over here. You see here the tumor and the carotid artery. I'm cutting the arachnoid here just to show, just to expose the tumor. The apex of the tumor here. Look how it's pushing the optic nerve upwards, and I'm starting to coagulate the implant area here in the tuberculum cellular area. And as the tumor is coagulated here in the origin, so the vascularity of the tumor decreases. So I'm starting to make decompression, internal decompression in the opticocarotid space, and touching as less as possible the optic nerve, of course, to avoid creating more damage that the patient already had. And this is the resection of the internal portion of the tumor. I'm going to advance a little bit here. And this is a closer view of the tumor that is only in this part, and pushing the tumor just to be able to remove from the middle line here. And this is the last piece of the tumor. I'm not touching, there is no invasion of the optic canal. You see here, the tumor is growing below the optic nerve here. And so this is the last piece of tumor that I'm removing here. And at the end of the surgery, of course, it's necessary to remove the implant here. I'm going to advance here a little bit. And it's necessary to remove the implant, the dural implant here, to make sure that they are removing the whole tumor out. And this is the dura mater where the tumor was originated. And of course, when the dura mater is completely taken out, it's time to drill a little bit the tuberculum cella here, just to be sure that you are getting closer to Simpson grade 1 resection of this tumor. So this is the last part of the tumor when I am drilling the tuberculum cella here. I'm putting a cottonoid patty here to protect the optic nerve, and the drilling was at the end of the procedure. And this is the result, pre in the left side, and the post-operative result. You see the total removal of the tumor. This patient was operated on 4 years ago, and this MRI was taken a couple of months earlier. And you see here the tumor. I didn't touch the microadenoma, and you see how the microadenoma is not seen in the control MRI. And this is the pre and post-operative, and the patient in the axial view with no evidence of residual tumor, and the patient recovered. And this is the T2, imagine, the pre here, and the post-operative control, where they see the total recompression of the optic nerve here, and here in comparison with the pre-operative one. And see, here is the microadenoma, just seen in T2, and this is the patient's campimetry, where it's possible to see the complete recovery of the visual defect. So thank you very much.
Gerardo, can I make a point? If I agree with the transcranial approach, but if you're gonna bother doing a craniotomy, I don't know. I drill the clinoid on every tuberculum cell meningioma. I do it extradurally. Sam Al-Mafti has always been right. When you say you don't see tumor in the canal, you did not open really the canal to inspect. I've been surprised at least 50% of the time, a little tail goes in the canal. That's number one. Number two, Teet Mattison paper from several years ago showing us, at least in their hands, if they drill the clinoid before manipulating the tumor, their visual outcomes were better. I think we miss out on that extra visualization and extra safety point if we don't drill the clinoid and don't cut the falciform ligament on every tuberculum cell, if we're going to do it transcranially. But I don't know, what are your comments?
Very good point. But I have seen in 2 cases that I drilled the canal. I didn't find any tumor inside the canal. I opened the ligament, the falciform ligament, and the patient had some evidence of deterioration of their vision. So in that case, the patient is an ophthalmologist. And so I was very under pressure about preserving, no matter how, the visual acuity and the visual field function in this case. But it's a very good point. If you open the canal, you can mobilize the nerve much easier, and you can remove the tumor in a very easy way.
Gerardo, I have a quick question for you. Let's say you were doing the same case next week after this meeting here. The first question, would you change anything? And if you did a craniotomy, would you go contralateral now after seeing the Dr. Schroeder's presentation?
Yes, a very good point. Yes, actually, the artery was not invaded by the tumor. If I had to retreat the patient, to operate the patient again, I would made it to the left side. Yeah,
I agree.
Can I survey the panelists and the speakers? If you're doing a craniotomy and a tuberculum cell meningioma, who among you would drill the clinoid routinely, or is it selectively or never? Anybody?
I'll talk on that. I do it every time. I mean, that's once I do the craniotomy, I actually try to stay extradural, and I'll show that in my next presentation. But the first thing, once I get to the tumor, I back out, drill the clinoid, cut the falciform ligament before I even touch the tumor. I do that on every sinwill case, and I always come back to that.
Do you do that extradural, Nancy?
I will open the dura, and you'll see subfrontal. So I open it far back. I do not expose the superficial brain, and I'll cut it, find the tumor, and then basically take the clinoid off. Extradural, essentially. You'll see it in my video, but I believe in doing that first off, because once you start manipulating the tumor, that's really where you're probably likely to get visual deterioration.
Yeah, so I guess I do a little different. When I go intradural, then I expose the tumor, like you're saying. I don't jump into the tumor. I do use now. I used to use a drill. Nowadays, I've been using the ultrasonic aspirator, and then I open the roof of the canal, and then I use a feather blade with a little angle, and I cut the falciform and part of the canal when I'm coming with the craniotomy. And that you can do that on the contralateral as well, if you have space. Sometimes a big tumor, you just do that at the end on the other side.
Yes,
I don't take the whole clinoid out.
I do it intradurally. So I look inside, and then somebody will see that the tumor is squeezing the nerve, and there's really a grooving because of the falciform ligament, and the tumor is pushing from below. Then I cut the ligament, and then I drill the canal open. But sometimes there's no invasion, and when you see it very well on the MRI nowadays, and also when you look with a microscope or an endoscope, you see that the tumor is extending into the canal. Then sometimes I don't do it in the smaller tumors. So it's very variable. I don't do it on a regular basis. But in most cases, when there is invasion, of course, I open it first. But you see if the tumor is squeezing the nerve. So the falciform ligament, I open every time, because there is a little bit manipulation to the optic nerve.
Yeah, and then
go ahead.
No, I just want to say that for anterior clinoid meningiomas, which completely shift on top of the anterior clinoid, then I go extradural to take the clinoid. And then I open the door after taking the clinoid out. So it's a little different.
Yeah.
Well, I'm putting together my series, and I don't know the percentage yet, but there is a large percentage of unsuspected little tail. I'm not talking big chunks, little tails in the canal, and that had been Sam El-Mefti's experience for many years. Ian can tell us. I don't know. Ian, isn't that right? What?
Very much so. Yeah, I'd say I have some experience to you, Jacques, which is an automatic clinoidectomy, and hard to always ascertain an MRI where you're going to find a tail or not.
And Jacques, you know, one thing too, I think that taking the clinoid off, it gives you access to that medial optic canal, which gives you some visualization of that tuberculum region. It does enhance the exposure of the tuberculum area so that when you get the whole tumor out, you can really be aggressive with resecting that tuberculum dura. By taking the clinoid off, it gives you that window right there, medial to the optic nerve.
Henry, I'm going to push you a little bit on the steepness. I don't completely disagree the steepness of the cella, but I've seen in your video and I've seen your techniques, I mean, you use an up-angled bipolar. So what stops you on that case of Gerardo of using that up-angled bipolar to go down the back of that? I mean, that's how it's done,
it's
no?
an option. I agree.
Yeah.
Frequently, it's an option. But sometimes it's very far down and it's difficult to reach it. You see, sometimes it's strange. Sometimes very strange how steep the tuberculum can be. But usually, of course, you can use the endoscope from above and from below. So the endoscope is not the difference. It's just the trajectory coming from below or from above.
Yeah, no, but what I'm pushing you at is, since you've convincingly shown, as it's been my experience, I was going to say my experience mirrors yours almost exactly the same, this spillover of meningioma over the anterior clinoid. Why are you willing to forget that point? Because that's what you're doing by going transphenodally on a case like this. You're telling yourself, she may have, you know what I mean?
But this small tumor, that's usually it's not the spread on the side. So I think in the larger ones you have but if you have a small tumor, I don't think there is a high risk to leave some tumor behind.
Yeah.
It can happen, yes, of course, but I think it is mainly in the larger tumors where you have these unplugged rows laterally.
Okay, Madison, you're up. If you unmute your mic.
One
sorry, go ahead, Henry.
Yeah, I think in this case you have seen that the tumor was mainly below the optic nerve. Sometimes you have tuberculum cell meningioma push it everything lateral into the back, and you have a lot of space to manipulate. But here you have seen the tumor was completely under the optic nerve, and then I think it's a good option to come from endonasal. It is a small tumor, it's just midline. So the risk that there is invasion of the carotid wall is very low in these tumors, I think, when they are so small. And it was very soft, what Danny said, it was very bright in T2, so I expect it's not a hard tumor.
Madison, go ahead.
Okay, Jacques, it's great to be a part of this. I really appreciate the invite, and it's great to be with everyone else on this webinar. So, of course, there are some, at least I would think everybody would choose endoscopic for this, and then I would think everybody would choose transcranial for something like this. But I do think there's so many tumors that are somewhat in between, and this is one of them. So this is a 45-year-old female. She came in to the outpatient clinic with progressive visual loss, right greater than left. And then the decision or question is, what do you do? So the two approaches are going to be endoscopic versus transcranial. And I would love to hear some input from everybody on the call.
A clear indication for a transcranial.
Yeah, so yeah, I agree. Madison. So
can you, Danny, can you summarize for the audience the factors that are making you go?
Yeah, the factors that are the things that I quickly see here in this case. It's if you look at the coronal, where you have encasement of the anterior circulation there, I think there's no reason to suffer and risk the patient with endonasal in a situation like this. The other aspect is in the right side. So in the left, it looks like the tumor is only medial to the optic canal in that third picture there. You can see the optic nerve. But on the right side, it looks like there's spill of tumor on top of the optic canal going past there, like more like on the anterior clinoid. So that is a case probably doing from the right side. I like the idea of taking the clinoid, and I might start doing that. I kind of was able to visualize what you guys are describing. I always did intradural, but maybe for large tumors can be done even extradural. But those are the two aspects. The fact that it's encasing the arteries and on the right side is spilling on top of the anterior clinoid. I think that's it's something that it will be better to do endonasal. Sorry, craniotomy, not endonasal.
Jacques, can I make a comment?
Of course, I was about to invite you right now.
All right, I appreciate it. I've been very quiet. So we recently reviewed our series of plain and tubercular meningiomas, and we looked at what are the factors that led to subtotal resection. And we looked at encasement of the ACAs as one possible one. We looked at either less than 25%, 50%, or 360 encasement of the ICA. And then we did the same thing with the optic nerve. We created what's called an optic nerve laterality score, if it goes lateral to the optic nerve or not. And we found that the ACAs were really not that important. Even if you had 360-degree encasement of the ACAs, you could get the whole tumor out. It might take longer, it'd be a longer dissection. You could get it out. But if you had 360 circumferential encasement of the ICA, that was a problem. And as Danny mentioned, if you had tumor lateral to the optic nerve, so you had a score greater than 3, that was a big problem. And then reoperation also predicted worse outcomes. So for this case, it's not as much the ACAs that would make me say, I'm not sure I can get this, but as Danny pointed out in that third image, there's tumor lateral to the optic nerve on the right side. And that could be tricky. I mean, it depends because you're coming at it from the front, right? You're not coming at it from below, so you may be able to get that tumor off based on the angle at which you're attacking it. But I just wanted to throw out there that that ACA encasement is not in and of itself a contraindication to endonasal surgery.
Yeah, and I agree 100% with everything you said, Ted. The one thing though that I can tell as I'm getting older, it gives me more anxiety to clear that ACOM from coming endonasal than when I do an open approach. So then, you know, instead of spend that anxiety, I'm getting older, so I come with a craniotomy these days for that encasement.
Usually, Danny, that's proportionate to the deterioration of manual skills, but that's okay.
Yeah, no, but I agree with you. Like the lateral extension is really what makes the incomplete resection here.
Ted, while you're talking, unmute yourself. I'm going to sneak in one question just because you were talking from our good friend Eduardo Velutini. Eduardo, how are you from Brazil? He's asking the gasket seal technique for tuberculum cella meningiomas with opening of the optic canal. How do you avoid compressing the optic nerves?
Yeah, you know, I tend to do more of a soft gasket or a button closure when I open the optic canals very widely. I do get afraid, and we're actually writing a report on how often we see optic nerve deterioration, and it's not that common. But if I open the optic canal widely, I'll do an inlay-onlay of Alamax, some fat on that and nasal septal flap, and I'll do a softer closure depending on the degree of opening of the optic canals.
Okay, go ahead, Madison.
So my mission statement on meningiomas in general is maximal tumor resection with minimal morbidity. So I do not really have a ton of experience using the endoscopic, microscopic combination that Danny, that you had talked about. I try to do it all in one procedure. So looking at this, the big things that kind of steered me towards the transcranial approach is the anterior extent of the tumor. A lot of times those dural tails that go anteriorly, the endoscopic approach, we tend to focus on the mass itself and leave that behind. And in actuality, that's tumor. And then that third picture down on the bottom right that you guys all pointed out, the tumor that was going superior to the optic canal and a little bit lateral to that, I really thought I'd have difficulty getting that out. The vascular stuff really didn't bother me that much at all, but I did not think I would be able to get the tumor out as I would be with the transcranial route. So the interesting part about these webinars, about meetings like this, is that you see how we all do it quite a bit different. For me, I like the orbital frontal approach to these, so I don't like shaving hair. I just use Vaseline to spread. Like Henry had talked about, I really like the zygoma to be at the top of the field. I do a suprafascial exposure, so the fascia and the skin flap go forward. It exposes the frontal process of the zygoma. I do like to preserve pericranium, not so much for the skull base closure, but I like it to cover the plates. I think it does help with cosmesis. And then you can see with the muscle, there's no need to really move the muscle in totality. All you need to do is see the region of the pterion. So just a little window right in there, and then the craniotomy follows. And once I get the craniotomy off, then that's where I move towards the bone work. So I do an aggressive drilling of the orbital roof, taking away all the little bumps. Then I do an extradural anterior craniotomy, which you see right there. So there's the ipsilateral optic nerve and the extradural plane. I use stealth to figure out where my opening is subfrontal. I do not. I try to make every operation as much as possible an extradural operation. So it really, to me, helps with retraction, and you'll see some T2 and flare pictures in just a second. But this is opening the falciform ligament, really widely opening the optic nerve, and then that's when I start to do my tumor resection. So this is removing tumor off of the tuberculum area. Contralateral optic nerve comes into play there, and the tumor is really easily removed with this approach. As you can see, I mean, really there is no exposed brain. There's no sylvian fissure dissection. I don't like even releasing CSF. I like to make a window in the tumor and then let the brain feed the tumor to me. So this is the final removal of the tuberculum dura. As we were talking about, that little extradural craniotomy, or the craniotomy in general, gives you some access to the medial optic canal, which allows you that window to safely resect that tuberculum cella dura. And so I really think it helps get you at least as close to a Simpson grade 1 resection in these kind of tumors. And then there is no dural closure like a parachute. I think the CSF captures that leading edge, and then the bone flap goes into place, alluding to the vascular supply of the native vessels. This was the right A2 and the left A2, and something that is very difficult to handle from the endoscopic approach. These little perforators that come in the tumor are easily handled with the microscopic transcranial approach. Very difficult from the endoscopic approach. Very close. I mean, that little perforator did not have much distance to it. It would have been difficult from an endoscopic. So this is the post-op, and I think you can get these great resections. Like I said, it's close to a Simpson grade 1. We have 51 tumors that we resected here since I started. No CSF leaks. Visual improvement about 67%, and we've got a 91% tumor gross total resection rate. And you can see by opening the subfrontal dura low, I really do think it absolutely keeps you from doing too much retraction during the case. So this is the T2 after removal of that. There's absolutely zero T2 change post-operatively. And then cosmetically, I really believe in cosmesis. I'm not sure if it's bald or it's because I'm ugly, but I do like to keep people looking as pretty as they can. And no way you could tell that this person had a craniotomy. So going back to my mission statement, I really do believe that gross total resection, maximal tumor resection without introducing additional morbidity is the goal of any meningioma surgery. And this was the cover of the Red Journal in 2007, which is a long time ago, and I get that, but it's really egregious to show that on the front page of a major neurosurgical journal when you see that dural tail that was completely avoided. So I think the optic canal through the transcranial route can be handled both medial and lateral, as well as that dural tail anteriorly, and thus it's really the treatment of choice for me for most of these tuberculum cell meningiomas. I consider the endoscopic approach an option, but not a replacement for transcranial.
Thanks, Madison. Any comments from any of the speakers or panelists before I invite Ted to maybe share his slides?
I would make one quick comment. You know, I recently wrote an article and reviewed the whole concept of the Simpson grading. And one of the things that you showed there was that question of a dural tail. And, you know, the dural tail is not always tumor. And I'm not saying that in that case it wasn't tumor, because it may very well have been tumor there. But sometimes there is hypervascularity that extends laterally that is not tumor and does not need to be always removed, which isn't to say that it didn't in your case and in the case you showed on the cover of the Red Journal, that looked like dural tail to me. But I would point out that but you see that radiographically, a dural tail is not always tumor. And there are more sensitive ways to figure that out. For example, we can do dotatate PET, things like that, that are specific for meningioma that can answer that question for us. So it's just something to think about. Any other comments?
No. Do you have slides, Ted?
Yeah, I wanted to show, this is a very quick thing that I presented. So first, of course, I have to respond to Henry, who I have such respect for. And I have to say, Henry, the best, using someone's own articles against them is brilliant. And I respect you immensely for that, and I appreciate that. But I do want to say that we looked at that same question of reviews of the literature. And this is an imperfect way to compare any approach because, you know, the cases are not exactly the same cases. And you were right that prior to 2012, the gross total resection rates were not as good. The CSF leak rates were much higher. And the visual improvement rates were really not that much better. They were maybe slightly better. It was not statistically significant. But we revisited the literature and looked only at endonasal cases from 2012 to 2017. And the gross total resection rates were higher. The CSF leak rates at some centers were lower. And the visual improvement rates on the whole were much higher than transcranial had been traditionally. Now, that being said, there's no question that in certain experts' hands, such as yourself, your results are always going to be on the high end of what you see. And I'm not trying to take away from that. And the study we did at Cornell, where we compared endonasal to transcranial, those were the actual results that were done at our center, not by myself, but by other surgeons. And so it was just a way of comparing it at one center. I'm sure in your hands, those results would have been better. And that's a very difficult thing for any of us to control for is, you know, everyone's results are going to be different. One transcranial surgeon is going to get different results from another transcranial surgeon. Someone may be better at endonasal than transcranial. And obviously, you want to do whatever in your hands is going to give you the best results. I think that's something we can all agree upon in terms of what we choose to do. But I wanted to present two quick cases that I had done in the last couple of weeks that made me think about different approaches. So one is an olfactory groove meningioma, 47-year-old woman, normal olfaction, incidentally discovered. I only have these three films to show you, but just quickly go around and let's just discuss what you think based on these three films the right approach would be. I'll ask somebody. So Danny, why don't you go first and then I'll moderate just to make it faster.
Yeah, so although these will be a direct approach for endonasal, you could take Cristagalli and open and take this whole tumor out. Like I mentioned during my talk, it was, you know, I've been really prioritizing the olfaction. I don't think this you can preserve olfaction in somebody with a normal olfaction. I would do this. I don't like an eyebrow for these olfactory grooves one, because as you saw Dr. Schroeder's presentation, you do need to struggle a little bit and put an endoscope in order to really see anterior. So I prefer a little taller, a little like a frontolateral or called a frontal-orbital craniotomy, not really taking the rim, but just having a larger a little bit. I will do unilateral right side coming with a frontal lateral approach for these.
Right. So I don't want to cut you off. I'm just trying to move. Right, so you do a craniotomy from the right side, frontal lateral, take the orbital rim. Yeah? Right.
Usually difficult to preserve olfaction ipsilateral, but like Dr. Schroeder mentioned, the contralateral, usually you preserve it.
Right. I think those are great points. Jacques, what would you do?
Left craniotomy. It's eccentric to the left. I'll have a better time preserving the right side if I come from the left. I'm
the
talking
right
about
side olfaction.
Yeah.
Right.
Yeah.
Michael, what about you?
I would come from the right orbitofrontal. I wouldn't do endoscopic just from the olfaction standpoint.
Right. Henry?
Probably frontolateral. It doesn't matter whether is olfaction preserved or not. I would come transcranial for sure, and frontolateral would be a good option. If the patient would prefer eyebrow, I also would consider eyebrow, but I think it's technically easier with the frontolateral because the craniotomy is a little bit higher. You have a better look down to the olfactory groove, which goes deep down.
And Gerardo, anything to
I
add?
would do an interhemispheric frontal approach. It's a small craniotomy in the front and splitting the frontal fissure, and you get immediately to the tumor with bilateral control of both olfactory nerve that could be preserved.
Right, that's an interesting point, is that you may be able to preserve both coming interhemispheric. So what I chose to do was an eyebrow incision, and I agree you do need to use the endoscope to see down into the cribriform plate and to see the cristagalli. You cannot do this with a microscope alone. But if you have the endoscope in the room and you can bend an instrument, I use the element or the eloquence, you can bend it, you can burn out the whole bottom. The only thing you can't do is take the cribriform plate. And that's another thing to talk about. When you do a small approach, in what percentage of these would you remove the cribriform plate, in which case you would impair olfaction 100% of the time, versus not do that, but you may leave some bone, there may be some hyperostosis of the cribriform plate. Do you inspect that beforehand? And in which cases would you drill out the cribriform plate and take a big pericranial flap? Just quickly, Jacques.
No, I think olfaction is very important to try to save. Let's give her, you know, the average time to recurrence when you leave hyperostosis in the anterior skull base is about 7 to 8 years. Let her enjoy 7, 8 more years of smell, olfaction. If it recurs, then we come back and do a bigger job.
Danny, you agree?
I agree 100%, and I think Henry showed similar, where he was not very aggressive with the skull-base implantation. I do exactly the same. Try to go endoscope, scratch around.
Anyone disagree?
No,
Totally agree.
And I think that's a great point. And you know, we talk about hyperostosis, but I think the recurrence rates with hyperostosis, particularly in the cribriform plate, are not as rapid as we think, and it's not so essential to get that Simpson high grade with impairing of olfaction. I think that's important. And also, stereotactic radiosurgery of the cribriform plate is actually very effective and also preserves olfaction, at least based on reports. So I wanted to just make this point from that same paper that obviously endonasally, your rate of anosmia is 100%, and you can preserve olfaction at least half the time, depending on the size of the tumor, if you do a transcranial. So I agree, coming from above is the right thing to do. And if you look at the endonasal gross total resection rates and CSF leak rates, which are presented below, they really are quite high compared to transcranial approaches. So I think the jury is out as to whether in which whether in which olfactory meningiomas should be removed endonasally. I'm not a big fan of it. I know some people do it. I think it's still a matter of debate. So one small planum tuberculum meningioma I'd have to present. So 54-year-old woman, decreased vision in the left eye. Now, what's interesting, this was the image that I got on my pre-op brain lab, and the residents saw what I was going to do, and they looked at this case and they're like, I don't understand, why are you not taking this out through her nose? This seems like a great endonasal case. And I pulled up a prior film that I had in the office when I saw her, and this is another slice of that same image. So I said to them, look, there's tumor lateral to the optic nerve here. It's on the clinoid. You are not going to get that out if you do this endonasally. I would not recommend endonasal. We're going to do transcranial, but I'll raise the question to everyone here, which I assume everyone would do this transcranially. Ipsilateral, contralateral. There is tumor in the ipsilateral canal, but there's also tumor lateral to the optic nerve in the clinoid. So do you come ipsilateral, contralateral, eyebrow, or terional? We'll start with Jacques.
Left side, as I said earlier, complete extradural clinoidectomy, particularly on a clinoidal meningioma. And then that gives me this almost 360 degree around the optic nerve. You can certainly do it eyebrow left side, yes.
Danny?
I would do ipsilateral in this case, because very often you see even further implantation around the clinoid on top of that almost getting to the cavernous sinus, as you can see there in this anterior clino meningioma. So I will come ipsilateral with, it could be an eyebrow or a small craniotomy left side.
Michael.
Yeah, I would do an orbital frontal. I mean, I like incisions behind the hairline. I mean, I will say, Henry, with all due respect, you kept saying the word usually with the eyebrow. And in an old person with a lot of skin creases, it does work well. But I will tell you always with the incision behind the hairline, it's cosmetic. But I would come in, just like Jacques said, left side, extradural anterior clinoidectomy, remove the tumor.
Henry.
To me, it looks a tumor which comes from the clinoid and is pushing the optic nerve medially. So I would come from the left side eyebrow. I think it's not that there's no tumor medial to the optic nerves. And of course, I would come from the contralateral side because you look so nicely into the contralateral optic canal. But here it seems to me that the tumor is pushing the nerve medially. So every tumor is lateral to the optic.
So what if I tell you, Henry, that on other images, it's both medial and lateral? There's definitely tumor in the medial optic canal, but there's also clearly that lateral tumor. Does that change your
yeah,
point?
then probably I would come from the right side.
From the right. And Gerardo.
I'm a fan of Deterioration approach. I would do a left Deterioration approach, but I'm drilling the anterior clinic process intradurally, and of course, on roofing the optic canal.
Yeah. So I ended up coming on the left and did a terional, and took out the clinoid and drilled the optic canal. Henry, the question I really had, because I do like the contralateral approach to get to the medial optic canal.
Yeah.
But I worry that the optic nerve is going to get in the way of me getting to that lateral tumor if I'm coming from the contralateral side. And so I think if you come ipsilateral, you can essentially almost get 360, like Jacques said. But I would worry about getting lateral to the optic nerve from the contralateral side. Do you comment on that at all? The ease of that?
Yeah, I think you can come above the optic nerve to the other side. The tumor is not very big. And you can also use the 30-degree endoscope to look down on the clinoid laterally. I think it is possible in both ways.
But Henry, I'm sorry, why not have the approach that guarantees you're going to see every corner of it, which means in the canal, lateral to the optic nerve?
No, Ted said there is medial to the optic
on
nerve
both
tumor
sides.
in the canal. Then you cannot see it because it's hidden under the ipsilateral optic nerve. Then you need an endoscope to look under the optic nerve. So if the major part is in the canal, I found it much more beneficial when you come from the other side because you have a straight look. So if it's pure tuberculum stellate meningioma, usually it's much better you come from the contralateral side because you look so nicely into the canal.
And Henry's right there. The hardest part of it was the ipsilateral canal for me. There's no question. I drilled it out as best I could, but that was the blind spot. And I guess I'm worried that if you come contralateral, that will not be the blind spot, but the blind spot will be what's lateral to the optic nerve. So, that's the question. Well, the optic nerve is always going to be in your way. Anyway, this was the results, and that's the end of my slides. Thank you.
Fantastic. This is really such a great session. So, Carolina, are you with us still?
I am.
You guys, I introduced Carolina, and I don't know if Mike Ivan is here. I know he's on vacation with his family, so, but if Mike is available to also join us, I'm not sure. Carolina, please help us out with audience questions. You run the show.
All right, there have been a few questions, excellent talks and cases. So Danny, somebody asked, if somebody does have loss of olfaction and you are gonna go through the cribriform plate for endonasal approach, is there any particular maneuver that you do to minimize post-op CSF leak?
Well, is the reconstruction. I don't believe in doing less opening in order to have an easier way to close. So we optimize. I take the dura, very often take the dura even on the roof of the orbits, and then only at the end we kind of look at that. Okay, now we have to close. But then nothing special. Then we'll do the collagen matrix inlay. More frequently nowadays we are complementing with the fascia lata as well. It started after we visit our friends from Milano and Varese. they use the fascia lata inlay and onlay, and then Ricardo start kind of, we saw the way they do, and it's very interesting. So one trick that they do is before opening the dura, you dissect the epidural space, the roof of the orbit, laterally, epidural, extradural. So at the end, that tissue is dissected, because if you leave at the end that dura is open, basically you don't have like ways to dissect it anymore. The dura is floppy there. So by dissecting earlier, so we actually use a fascia lata only extradurally, that you put it on top of the orbits laterally, and then we bring the flap. So we've been doing that more recently for the last couple of years. So that's, I guess, the only new trick that we have. For these, we don't use the gasket seal soft. Like, it has to be a smaller opening to do like a gasket seal for soft gasket seal. And Rick doesn't like the try to do the firm gasket seal. Like, it thinks it's kind of somewhat a foreign body as well. So that's why we started doing this only with the fascia lata.
Can I ask a question to the panel related to that? I've started trying to move away from fascia lata because I do have patients who complain about the thigh incision. Now, we are trying to do minimally invasive surgery. Have you ever tried to use Alamax or Alloderm or something else instead of the fascia lata? And we haven't had very good results with it. So I'm just curious if other people have tried to use.
We've been here in Miami. We've been Alloderm users since Roy Cassiano, my ENT colleague, has used it since the mid-90s, and we kind of inherited his technique, and we're very dependent on it. Now, it's not completely free of trouble. Henry showed, I don't know if you saw part of his presentation, he showed the case of an intracranial abscess due to, I don't remember what material, but I've removed 2 brain abscesses following an endonasal. It was a malignant case, but big alloderm. That has happened. We've had to use fat to augment alloderm following proton beam. So it's not, answering all problems, but certainly very handy.
Yeah.
Henry, tell me about that case. You had an abscess from alloderm?
No, it was a fascia lata. It was a recurrent case after olfactory groove meningioma transcranial surgery. And we make an endonasal resection, and probably our flap was not long enough. That may be the problem. But I try to avoid, in any reconstruction, I try to avoid any all materials which are not autologous. So I try always to take something from the patient. But we try to avoid fascia lata because of the pain they have at the donor side. So usually in most of the cases, we put fat and fibrin glue and the flap.
Yeah,
go ahead, Madsen.
No, we haven't used fascia lata at all. We do place fat intradurally, and then we follow it with gasket seal, and then nasoseptal flap over that.
But what do you use the gasket? What is the gasket done with if not fascia lata?
I will use just a dural allograft that will be extradural onlay, and then the gasket seal we use MedPore and basically push it extradural intraosseous, and then an onlay over that, and then a nasoseptal flap over that. And we haven't had any leaks. You've got to cover that MedPore with something. It definitely will be rejected if you don't cover it with something. But I've used that from the beginning of my career, and it served me well. We have not had any leaks using that.
I've had one patient who main complaint from a complex surgery was leg pain for so long that I've abandoned that as well. And we've used occasionally cadaveric fascia lata.
Danny, as a follow-up, how often, like if you have like recurrent CSF leaks, have you had to do the bicoronal incision pericranium and then pull down through to cover?
It's very rare. The main cases that when you ask a question a couple cases came to my mind where we had a disaster. We actually, it's all published, where we gave proton beam after anesthesio surgery, which is very similar opening, the entire anterior skull base opening there. And then the reconstruction that we used fell apart, but with necrosis. And for those, we had to reopen with the bicoronal, lift the brain, use even, at that point, the brain has edema because of the post-radiation, radiation necrosis. And then you do need to have support on the solid on the base of that. and we kind of reinforced. I had 2 cases we had to come back and reinforce, but both were related to radiation to the skull base and radiation necrosis and edema, and the brain coming down and pushing that reconstruction that we did endonasal. So it's not free of problems. One thing I want to add it up, going to what Ted mentioned, we did have one case, this is I think 7 years ago, where the flap was a redo flap, and the flap, when we elevated, that was in a meningioma, the reutilization of the flap was just not enough to cover the entire skull base, and we did like a Roy Cassiano technique, Jack, where we use alloderm for the rest. We don't know if it's related or not. This patient was diabetic as well, and she evolved with mucormycosis. I don't know if you guys saw that we have the 1002 TED paper that we showed at NASBS, and we just submitted now for publication, and it's going to be there. You'll see there's one case of death with mucormycosis that we had with vasculitis in the brain, disaster. And after that, in my mind, there was some relationship with the fact that part of the skull base was not covered with vascularized tissue. So we nowadays, we would actually do something else, you know, even a bicoronal, bring a pericranium, the same surgery. So sometimes for aesthesia, the aesthesia is more common, that is going to be destroying the septum. For those, we will do like in the same surgery, entire surgery endonasal, but we will bring pericranial from the top, and we will pass not through a craniotomy, but just through a glabellar incision, so through the frontal sinus, and then bring in vascularized tissue there. So we became more aggressive, like to have vascularized tissue on the reconstruction to avoid these problems.
Yeah.
Carolina, go ahead so we can cover as many questions as we can.
Dr. Schroeder, somebody was just asking if you could discuss the handling of the supraorbital nerve in the eyebrow incision approach.
Usually you palpate to found the incisura of the supraorbital nerve, and then the incision is lateral to that. But sometimes the course of the nerve goes more lateral. So it can happen that you have to be very careful because the nerve is running over your intended craniotomy. And we had also a case where I had to cut the nerve and suture it after the surgery because it's running over my field. But usually you remain lateral to the nerve. And then if you can identify it, usually I try to identify it, and then I protect it with a small hook when it makes a craniotomy.
Henry, can I follow up on this question? Where do you make your incision exactly? The upper edge of the eyebrow, the bottom edge, or in the middle of the eyebrow?
In the middle. I put it directly in the middle.
And you've not seen hair follicles growing, kind of aberrantly giving an ugly scar among the hair?
No, usually not. No, we have some, in the one lady, you see that the hair is not growing in the same direction, a few, but usually it's very nice, very well tolerated.
What about some of the plastic surgeons advocate for like the eyelid approach that they're going to use, that they would use otherwise for some of their like sort of facial lift procedure? What do you think about that, the eyelid?
Yeah, I have not done it. I have never tried it. I always place it in the eyebrow, and so far I'm not disappointed with it. I think it's, for me, would be more complicated, so I need an eye surgeon who is doing it for me. And then I don't know. There was also a report about transconjunctival incision, but I don't know whether it's the scar formation in this area is good or not. Some people say it's not a problem, but I try to avoid to get any interference with the eye.
There was a good paper, and I played around with transciliary and transpalpebral incisions, but recently that showed that the transpalpebral actually gives you a much better superior trajectory than a transciliary, because a transciliary essentially kind of forces you a little bit up, and a transpalpebral forces you a little bit down. So depending on what the pathology is, one actually might be better than the other as far as trajectory.
Yeah, on my hands, I also have done both. I think the supraciliar, like eyebrow, is better for anterior fossa. And, you know, like you pointed out, you have to have those 2 centimeters, Henry, like to be able to go down and see the optic nerve. Otherwise, if you like the restriction, if you try the eyelid for the anterior fossa, it doesn't really go up as much. And I felt a lot of resistance. So I used the eyelid for remove the lateral orbit, and I use for middle fossa in Sylvian fissure. if I want to do that. And then for the eyebrow is, for my hands, better for the anterior skull base.
Yeah.
Great, thank you. I'll ask all of the panelists to weigh in on this, but what's your opinion on the subfrontal interhemispheric approach? What situation do you find that to be a preferable approach, if any?
You mean interhemispheric?
Yes.
So I think if you want to go to the interhemispheric fissure, it's very difficult to make a good dissection because it's not like the Sylvian fissure. Usually you end up in the pia mater on one side or the other. It's not so easy to split it. So therefore I avoid it. I did it sometimes for craniopharyngioma in my early career, but I think it was not so easy to dissect both frontal lobes from each other because they're really sticking together and you end up in the brain tissue on one side or the other.
Yeah, I use for transcallosal things like that, but not for the area around the optic. Even for going through lamina terminalis, I use it a unilateral right side to go to the third ventricle from the front. I force my craniotomy to go as medial as possible to get a nice angle, but I also don't go through the interhemispheric fissure there.
What about in?
I think.
Go ahead.
I think the question is regarding the olfactory groove meningiomas and also the anterior skull, anterior floor base floor meningiomas. Is when in cases of a huge olfactory groove meningioma, the frontal fissure is already dissected. It's very easy to dissect. I agree that it's very difficult in cases of a tuberculum sella or even the lamina terminalis, but in cases of anterior located tumors, it's not very complex to make this dissection.
Are you? What's your concern in what you ligate? You suture ligate the sinus?
Yes, you suture the sinus as frontal as possible, as basal and frontal as possible, and there is no.
Right. So for those patients, do you ever get concerned about any? Some patients have sort of anterior venous drainage that is larger than normal. Would you ever get an angiogram? There's one of the audience is asking, in which cases would you indicate an angiogram?
The sinus is so atretic there that I think that's a very, very rare occurrence. So I personally would not feel the need to get an angiogram with that approach.
Can we expand that question? Do any of you use angiogram for arterial reasons for an anterior skull-based meningioma ever? Would there be any reason to do that?
I don't use it in any case.
No. I don't.
Yeah, I agree.
You promise not to shoot me?
Go ahead. Tell us, convince us though, why?
No, this is just a bad joke. But if you were an endovascular surgeon that did open surgery, I'm sure that you would do angiogram. So don't shoot me. That was a bad joke. I'm sorry. But I don't think there's a reason to do it on these tumors whatsoever.
Well, every other tweet these days is how an endovascular surgeon has embolized a meningioma prior to resection. So
yeah, there was one last week, right? Yeah.
I mean, I'm just a follower of Twitter.
Yeah, you see the vessels nicely in the MR imaging. There's no need for angiography.
Yeah, I mean, everybody has alluded to this, but there is some predictability to how these tumors interplay with vessels. And as we were talking about, Gerardo, your case, these tumors kind of give you their personality a little bit before you even meet them. So there are some that, of course, you're going to be in for a tough battle, and you know that the vessels are going to have significant interplay. And there's some that there's just going to be a chip shot. So I just don't see how vascular imaging helps you at all with taking these types of tumors out.
Okay. Do you have concern about the frontal sinus when you're deciding between eyebrow versus terional approach? How does the frontal sinus come into play in your decision making?
It's for me.
Sure.
Yeah, anybody, go ahead.
If there is a large frontal sinus and I'm going to open it, I would come with the skin incision behind the hairline, because then I can harvest a lot of material to close it. If you have the eyebrow approach, you have no autologous material. So I would never dissect or resect a little bit of the temporalis muscles because that does not look nice. And then you have to use artificial material, which is not very reliable. So if there is a very, very pneumatized frontal sinus, it's widely open, I would do it. If it's a small opening, I would simply use Tachosil to glue it on the suture line of the dura and the other piece on the bone. But if it's large, then I think it's better.
Carol, I have exactly I'll do exactly the same. I just want to add 2 cases early in my career that I actually forced an eyebrow. And I did a technique that was described even by Pernesky, where you could go, instead of go with your incision through the eyebrow all the way to the bone, you stop at the periosteum and you dissect like very far away, and you actually get a flap of periosteum up, and then you do your craniotomy. At the end, you have something to cover your frontal sinus. So the problem I had is that both of these 2 patients that I tried this technique, it actually worked well, but they had a frontalis, probably by me going into a plane where the frontalis was. So then I stopped trying to do that. So I only do eyebrow, I go the incision all the way to the bone, and I elevate the periosteum at that point.
Yeah.
Okay, what are the considerations for when to put a lumbar drain for these cases?
Usually no indication.
Yeah, I don't use it as well. Only if the patient leaks, I will consider putting an indication if I need to take it back to the operating room, but not as primary utilization.
Yeah.
Ted, Ted, you're a liberal user of lumbar drain, but maybe not for meningiomas. Can you comment on lumbar drainage? Did we lose? You're muted, Ted. Oh, that
his
is
voice
funny.
changed. Huh?
Your voice changed.
Something's happened to you.
Oh, you'll have to watch the recording of this session. This is hilarious. Try again. It's like having helium in you. Oh, that is funny.
I think that happened.
Where have you been? What had you after surgery?
We cannot understand you, Ted. I'm not sure.
It's like chipmunks.
Ted, what have you taken after surgery?
There is something wrong with the audio on your end, Ted. I'm not sure what it is.
Hey, how's this? Is this
there you go.
Oh, he's back.
What did you do?
My computer restarted and maybe it went to a different microphone, so I switched it. So what I was saying is for lumbar drains, we only use it on endonasal cases where we expect there's going to be a very high flow leak. So it's only certain cases. And if you look at the randomized study that University of Pittsburgh did,
right,
they found that a lumbar drain made a statistically significant difference in the cases which in their hands were high flow, high leak, high risk cases. At every center, it's going to be different depending on what is a high risk case. But clearly it makes a difference in high risk cases as per randomized double blind, it wasn't blind, but a randomized study. So for that reason, if it's going to make a difference in some cases, even if it's only 10% or 15%, we put in everyone who has a meningioma or a craniopharyngioma or a big chordoma who's going to have a big leak. We'll put a lumbar drain in. We'll take it out after 24 hours. We don't leave it in for a long time. But for that first 24 hours, it allows there to be good healing of the grafts that you put in, and less likely that when they cough or they sneeze or they get extubated or they get moved from stretcher to bed, that increase in ICP will blow out your closure.
We use the lumbar drain when we open the third ventricle for craniopharyngiomas. I think that that is very good. But to backroom meningioma, usually if the arachnoid is intact, I think it's not required. And for chordomas, always we do it. If the chordoma is interdural, posterior cranial fossa, you have a high pressure, then always we leave it. But we leave it for 5 days.
Carolina,
okay, one final question, and this has come up interestingly a lot in the conversations in a lot of these meningioma symposium. But anyone's using stenting prior, like carotid artery stenting prior to surgery, if the tumor is encased by the meningioma.
Prophylactic stenting, no.
I know, comes up a lot. It's an interesting thing that people keep mentioning.
Well, it's probably more applicable to, recurrent cavernous sinus meningiomas, like the conversation we had 2 sessions ago, but yeah, not for this.
Yeah, I have experience with one case. It was a chordoma, not a meningioma. That patient had a carotid rupture, so had stent already, not intentionally put it there. So when I went to dissect, it was very, very nice to have that wire there protecting the carotid. So we were able to be aggressive around the carotid, but it was not intentionally inserted.
Danny, that patient wasn't on antiplatelets?
Yes, good question. So it was inserted a while before, more than a year. So so we stopped for surgery. Actually, we did with the 81 aspirin, but we stopped some Plavix that was on board and other things.
It was somebody who had gotten resected and had an injury intra-op, and then they stopped the resection, and it was
Correct. And then it grew back, and they put a stent there, and that's when I dissect around the stent.
My largest experience with stents is mostly with like glomus caroticum tumors in the neck. We've done covered stents, and then, you know, it immediately devascularized the tumor. Then we waited a few weeks, and you cut down to the stent because the endothelium is on the inside, makes those surgeries much faster, and the embolization part is a no-brainer. But those are not very common. Okay. Well, any final comments to each other, panelists, speakers? Final chance before we all go to dinner and or Henry goes to bed.
Yes. I would like to join you for dinner, of course.
That's right. Listen, this was a fantastic session. I'd like to thank everybody and for participating, and thank you the audience for sticking with us. And you can watch the recorded session later.
Thanks for
Bye,
organizing.
Yes.
Oh,
Thanks. It was
bye-bye.
good to see you guys.
Thank you, everybody. It was great.
Bye, Dan.
Great seeing everybody.
Bye-bye.
Stay safe.